Overall, the needle is pointing up, but it's probably not pointing up fast enough for many of these kids. It takes a long time to get these studies open. Once they get open and a kid enrolls, then you're just so hopeful that this is going to be it. This is going to get them to where they need to go. And if it does, just like, oh, thank you. It's just so fortunate. I mean, it takes a certain temperament to be in this field. And so it's definitely a calling that I've identified. And so as hard as it is to treat these children, to lose them, I keep coming back, so it's to try to think of, the children that can be saved and just, focus on on hope and yeah. Treating children with cancer is a challenge, even with the high success rates overall. Treatment is not easy. There's a lot of side effects. It's very traumatic, both for the child and for the family. It's changing their life forever. There's a lot of ups and downs in the treatment, and although most of them can be cured and have a success story, some of them don't. You don't know who that's going to happen to, and you build relations with all these families. But I think it's an understanding that we can only do what we can do, and we try our best with everyone, and I don't come in with the idea that they're all going to be cured. I come with the idea that I'm going to treat them all, and hope that they'll be cured. If one thinks that you're going to cure everyone, then that can be very difficult, because that's not going to happen. And so again, it goes back to the clinical research. My area of interest is what's called epigenetic modification with leukemia. When I bring in drugs that can alter these epigenetic or cell pathways, we can collect the blood samples from the patients and send it to Dr. Rao, and he can then do the testing to know, did the drugs do what we thought they would? And if they didn't, why? It's a real critical partnership with the research side and the clinical side. If I were to develop a trial with different drugs, and I gave it to some kids and it worked, and I gave it to some other kids and it didn't work, and I had no laboratory tests to investigate why and why not, I would learn nothing. I would have a treatment, and I'd be able to tell a parent, well, it worked in some kids and didn't work in others, and I don't know if it's going to work for your kid, but why not? Let's give it a shot. So that's not the way to go about it. We need to understand the biology of the cancer. Why does it behave the way it does? And are there any aspects of the cancer that we can take advantage of and target with certain drugs that may affect, that certain cancer biology? And when we give treatments, to be able to understand which cancer in which patient responded like we hoped for, and which didn't, and then why. The biology tests on a clinical trial are as important as the therapy itself, because you can come away and understand, okay, it didn't work in this patient because of X, and we can fix that. The goal of developing clinical trials is not to keep developing new clinical trials, it's to find a clinical trial that really works. You test it first in the relapse setting, but if you can impact relapse, maybe you'll be able to impact even more patients who have not relapsed, so that they don't relapse. But that's the pie in the sky for this trial that we're starting here, and hoping to get enough early data to receive larger grant funding that we can make this a national trial, enroll more patients, and hopefully show the success to bring it up front to newly diagnosed patients.